Statement number one is IVF always results in twins or triplets. It's a myth or a fact?
It's a partial fact.
IVF babies are not as healthy as natural conceived babies.
They are absolutely healthy till now, right from the 1984. All IVFs are done, and there is no single paper suggesting, no scientific research paper suggests that IVF babies are abnormal. This kind of embryos are the top quality embryos, so we can get a better selection. Morphologically normal embryos, we don't really need to do invasive genetic testing to find out the morphology of the embryo.
Hello and warm welcome to MedSynapse podcast series, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today I'm honored to introduce to you Dr. Shital Punjabi with us. Dr. Shital Punjabi is a senior gynecologist and IVF specialist renowned for her expertise in infertility, gynecology, laparoscopy, and cosmetic gynecology as well. A gold medalist with advanced IVF training from Cleveland Clinic, USA, she has been in practice since 1997 and it's the founding director of Shashwant IVF Center as well. We are excited to have you here.
Thank you. I'm equally excited to share my views. And I really appreciate you taking on this educational activity.
We'll start with our first question for the podcast. Is let's talk about something exciting that's changed the game in IVF. About time-lapse monitoring. So, it's like a 24/7 window into embryo development. Can you suggest any morphological changes have been easier to detect with this technology?
See, basically, this time-lapse imaging is an excellent technology. It checks the embryo development continuously, continuously monitoring the development of the embryo in the incubator. There is a continuous monitoring of the morphology of embryo, the division of the embryo, and everything. So, as such, theoretically, yes, conceptually, yes, it is extraordinary technology, wherein we don't need to take out the embryo from the incubator, and we don't really need to check the culture dish with embryo frequently. That's how this ELI technology works. If you just consider theoretically, it is good that continuous monitoring of embryo happens. When we clinical results, what we have seen so far in all these years is it doesn't really help us in increasing the live birth rate. So that is the most important thing, the first and foremost I would like to say. Second, your question, what do we see in that? So one thing is, when we are doing this continuous monitoring of the embryo growth, we can check that, okay, the ICSI sites were converted into 2P and 2P state of the embryo after 18 hours. And it is like real time, and we really don't need to take out embryo. Then from that, we can see that, okay, this embryo is growing properly, dividing properly from 2 cell to 4 cell, then number of nucleoli, then appearance and disappearance of the polar body, and everything we can see nicely. From 4 cell, it increases to 8 cell, then morula, then blastocyst. We can see nicely development of the blastocyst, inner cell mass, and trophectoderm, and thinning of the zona pellucida, and at that time only we can take out the embryo and then we can select the embryo for the embryo transfer. So this is the beauty of this time-lapse imaging. And sometimes when embryo are the embryos, they are having delayed growth. We can see in this time-lapse imaging when they are very fast growing. That also we can make out that, oh, this embryo seems to be relatively genetically abnormal or something. It is very fast growing. When there is presence of vacuoles in the cytoplasm, we can check that. When there are multiple fragmentations, then we can check that also. So according to that, we don't need to take out the embryo, but on the basis of the real-time monitoring of the embryo in the embryoscope, we can select that, okay, this embryo seems to be morphologically normal, growing normal, and going as per whatever is mentioned in the embryo literature, that this kind of embryos are the top quality embryos, so we can get a better selection. Morphologically normal embryos, we don't really need to do invasive genetic testing to find out the morphology of the embryos. So this is the beauty of this embryoscope or a time-lapse imaging technique.
That was a great insight, Dr. Sheetal. So let's move on to the next question. Since you have been in this industry for quite some time, so what are the most significant changes you have observed in ovarian stimulation protocols over the past decades? And how do you approach a personalization of stimulation protocols?
See, for personalization of the stimulation protocol, it is extremely important. We call it ICOS, that is individualized controlled ovarian stimulation. So it depends on the basis of the age of the patient, for how long she has been trying to conceive, like that is how long the couple is married and they're trying for different treatments for their fertility. Third is the ovary, the baseline scan of the ovary, which shows that okay, what is the ovarian volume, what is the Doppler study of the ovarian blood vessels, how many numbers of embryo follicles are there. Most important is okay, whether the ovarian follicles are associated with some redundant cyst or some follicular cyst or some hormone dependent luteal cyst or some endometriosis or triplets, or there are some pathologies like the extreme polycystic ovarian morphology, something like that. So all these things when we check, once we check, and we do blood work for a hypothalamic ovarian axis. We check for FSH, LH, prolactin, TSH, AMH, estradiol, and progesterone. And this thing gives us idea that okay, the patient falls into either normoresponsive to the ovarian stimulation or hyporesponsive to ovarian stimulation, or she would be hyperresponsive to ovarian stimulation. We can make out that. Then on the basis of her uh, BMI, like we can check what is her height, what is her weight, what is her BMI. And other than that, if she has been taking some other medications, on the basis of that, we decide the molecule. We call it exogenous gonadotropins. So either they are HMG, that is human menopausal gonadotropin, or it is FSH, that is recombinant FSH. Sometimes we add recombinant LH as well, or sometimes we use different protocols, short protocol, long protocol, then ultra short protocol, then antagonist protocol. That also single dose antagonist protocol, multiple dose antagonist protocol. So what is our target? We decide that okay, what ovarian stimulation we will be. So long back when we used to study, there was only one standard protocol. That was long protocol. Then came a short protocol for those who are having poor ovarian reserve or less number of the antral follicles. And then now, because we want to avoid premature LH surge, now we have antagonist protocol as well. So fundamentally, we want two things: extremely good quality of the oocytes, which gives us live birth rate, and second, prevention of the complications. So in that, one important is prevention of the premature LH surge. Second is prevention of the OHSS. Third is prevention of the multiple pregnancy. These are the most common things which we are looking at, and that's how we decide that what should be our ovulation stimulation protocol.
That was a great perspective, Dr. Sheetal. So let's talk about something really important, the ethical side of IVF. As we all know, medicine isn't just about science. So how should our future doctors should prepare for the ethical side of IVF?
This is very, very important question. I really like this question. So basically, like what we are taught during our graduation and post-graduation is medical knowledge. Right? We are all having full medical knowledge, scientific knowledge, the complete theory, complete practical knowledge plus skill of doing like different surgeries, doing ovum pickup, doing embryo transfer, then doing embryology, everything. But those ethical dilemmas that we come across only when we start practicing. So this happens. So the most common dilemma in our country, in India, is a patient or a couple, they would come to us. I think that can you do gender selection for us while doing IVF? This is the biggest ethical dilemma while practicing in India. Here, legally, we are not able to help the patients by selection of the gender of the embryo or the child. This is something, yeah, and this is what we are never taught during our medical school. So I would definitely love to take advantage, to take the opportunity of telling to the upcoming future IVF specialists that the may come up asking for that, but we have to be very empathetic towards them. We have to be calm, cool, and considerate, and we have to tell them that this is something which is legally not allowed, and we would not be practicing that. So this is the first thing. So we can stand by them and tell them that you don't have any children as of now. So any gender, whether it is a baby girl or baby boy, you are going to get what you always wanted. You will be like from husband and wife, you will be converted into parents. So please look at that. So that is the biggest ethical dilemma. Second ethical dilemma, we are able to do extremely good, like genetic this, that, everything. But people come up with asking for get read Google and net and all, and they ask for designer babies. That a couple would ask will ask they'll ask for the blue eyes of the child. Now, when both the parents, right, the husband and wife, they do not have a like blue eyes genetics, no IVF can help them out. This is very very important thing. So other than that, sometimes the people they like go to different kind of parties, and by the time they are 40 they come down to the IVF specialists, and then they want their own baby, their own genetic material, right? Now, biological clock is ticking in females. Once any female crosses the age of 35, her fertility index goes very down. Her quality of the egg oocytes go bad. Her quantity or number of the eggs, they are so much so reduced. There are very, 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 very little chances of a couple having their own genetic material. For male, it is not so, but for the female part of the couple, right? The egg number and quality of the eggs are so poor that so many times it happens that we are, even if you want to help the couple, we are not able to help them. We have to tell them to go for donor side. So that's where also there is a big dilemma, and I appreciate you taking this on. Like I would really request that we can take this on for the general population as well, wherein we can sensitize them that after the age of 30, the number and quality of eggs go very bad. So we have to make sure that the first pregnancy is planned before a female completes the age of 30. Now, for those who are very highly educated and they are not planning the pregnancy before the age of 35, so then we can offer them egg freezing, that is fertility preservation program. So when a lady is 25 to 28 and she's sure that she's not going to have her first baby before the age of 35, then yes, we can help them by preserving those eggs. So then those eggs are preserved, and whenever they want to plan their pregnancy, even at the age of 40, the age of the egg, the biological age of the egg would be when she was egg harvesting was done. So if some female has done egg harvesting at the age of 28, if she wants to plan her baby at the age of 40, but her age would be 40, egg age would be 28, and she can have a normal, healthy, her own biological child. So that's possible. So this is one more important ethical thing. Ethical thing which we we are not educated during our medical schooling is, once a lady crosses the age of 40, some or the other medical disorders they come up, like diabetes, hypertension, sometimes some fatty liver or some renal changes or something. So before we offer IVF treatment to that lady, we have to check that during pregnancy whether she will be able to handle this or not. Her uterus will handle it, her medical system will handle or not. Will she suffer from some other gestational diabetes or extreme hypertension, what we call as preeclampsia. Sometimes it ends up getting eclampsia. So that we have to check. If she gets eclampsia, it is very, very risky for the mother and the child. So we have to check that. So this is one more important thing. That IVF is a sure treatment option for infertility, right? But we have to check for that. So in certain cases where the uterus is it is very much damaged, either because of tuberculosis or fibroids or multiple abortions or Asherman syndrome. In our country, tuberculosis endometritis is very, very common. So in those cases, we have to offer them surrogate uterus, right? So we have to go through the whole process of finding out the surrogate and doing treatment. That also is one of the biggest ethical dilemma. And sometimes the doctors not disclose this thing. They need to learn, okay, and how to disclose this bad news to the couple. And this female should not get the pregnancy in her own womb, and she should either opt for the surrogate uterus, or she can go for adoption. This is also a big ethical dilemma. I think major things though I have covered. Yes.
Yeah, that was a great, well put together answer in terms of comparing all the legalities and patient feelings as well. So let's wrap up the session with one last round with myths and facts. So I'll be just asking you some myths and facts, and you just have to tell is this a myth or a fact and give your answer to it. So statement number one is IVF always results in twins or triplets. It's a myth or a fact?
It's a partial fact because out of 100 pregnancies conceived by IVF, there are 25% chances of having twins pregnancy. Not all
Okay.
IVF are twins, 25% of IVF are twins.
Okay, let's move on to the second statement. IVF babies are not as healthy as natural conceived babies.
They are absolutely healthy till now, right from the 1984. All IVFs are done, and like there is no single paper suggesting, like no scientific research paper suggests that IVF babies are abnormal.
Okay, and IVF is only for women over 35 years.
It's not like that. The women who are like 22 and extreme PCOS having extreme endometriosis, or husband has zero sperm or extremely poor sperm numbers or motility, they also need IVF. So it's for
Okay.
all ages.
Okay, and IVF is extremely painful to the patient.
It is not painful. Yes, it is difficult as multiple injections, multiple visits to the IVF clinic, and going through processes, multiple like social, legal processes, taking daily injections and everything. Otherwise, it is not painful. Basically, I would say that it is less painful than a normal delivery.
Oh
I have
wow, that's a
conducted more.
lovely
Yeah, I have
perspective.
conducted more than 10,000 deliveries, and I
Uh,
pretty well with guarantee I can say that it is not painful as far as the
okay.
physical pain is concerned. Physical pain, right? Yes,
Okay.
emotional pain, social pain, managing the timelines, managing the work and the IVF balance and everything. Yes, it takes a toll on the couple, and particularly yes, it is very costly. So like takes more on the pocket as well, but physical pain is concerned, normal delivery is highest painful, even more painful than the fraction. So,
Yeah.
nothing to worry for the physical pain.
So the last statement is, can you change lifestyle habits to improve IVF success?
Definitely, yes. So we call it free IVF treatment, and we offer the free IVF sanskar to all our patients, wherein we give lifestyle changes and certain nutritionals, micronutrients, and all those things both, like male and female both, and then we start with the IVF process, and that increases the results. Not only the IVF success, second, during pregnancy complications are less. Third, a normal full-term healthy baby is delivered, and the baby is absolutely fine, mother is absolutely fine.
Okay, so that's about it for the podcast today. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions or contribute to the ongoing evolution of healthcare. So until next time, stay tuned, take care.